So, got it, recording in progress. So it's my pleasure to introduce Adi to give our research ground rounds today. Adi has been our fellow for the past year and a bit. She's joining us from Haifa in Israel, and we're very happy to have her. She's been an outstanding fellow in not just echo, but also MRI and CT. And today she's going to talk to us about some of the work that she's been doing, looking at cardiac MRI in patients with recovered COVID-19. So Adi, I'll pass it on to you.
Okay, thank you very much. I'll just share my screen here. Okay, can you all see my screen?
Yes.
Okay. So good morning, everybody, and thank you for the invitation to present our work here at Grand Rounds. I know that you're all very eager to hear more about COVID-19. So I'm going to present our work about the cardiac involvement of COVID-19 in recovered COVID-19 patients. Okay. So the SARS-CoV-2 virus was first identified in the Chinese city of Wuhan back in December 2019. And the immediate response by the Chinese government was to put the whole city and the surrounding cities in the Hubei area under complete lockdown. But as you probably know, this lockdown actually failed to contain the outbreak, and the virus quickly spread into the entire mainland of China and around the world. And the World Health Organization actually declared it to be a public health emergency of international concern at the end of January 2020, and to be a world pandemic on March of the same year. And well, nowadays, basically 2 years after the start of the COVID-19 pandemic, we are still struggling with it. As you can see, these are the data according to about a month ago. And here you see that we have basically 240 million confirmed cases and nearly 5 million COVID-19 related deaths around the world. From the beginning, we knew that in most of the cases, the disease will be either asymptomatic or have very mild symptoms such as fever, cough, basically the typical flu. But we also knew that in some cases it will be with severe symptoms, maybe requiring hospitalization. And we kind of knew that there are some risk factors for having severe disease and higher mortality. And here on your right side here, this is a table taken from a very good review paper published about a month ago from the European Heart Journal, showing you all the risk factors that actually correlate with higher mortality. And as you can see here, you have the cardiovascular disease, cerebrovascular disease, hypertension, diabetes, renal disease, and even obesity. All those correlate with higher mortality rates with COVID-19. And this is again from the same article, the same review, about the risk factors that correlate with the probability of having severe COVID-19. So again, you have the cardiovascular disease, cerebrovascular disease, hypertension, diabetes, and even smoking. So as you all know, COVID-19 is basically a respiratory disease with most of it having respiratory symptoms. But going on into the pandemic, we had a lot of data about the cardiovascular involvement in COVID-19. And basically it was the research was done on hospitalized patients. When I say cardiovascular manifestations, I mean myocardial injury, acute heart failure, arrhythmias, myocarditis, pericardial disease, and even thromboembolic events. All of those were actually well known and published in the literature. And there were multiple mechanisms that were suggested for this cardiac damage. Most of the mechanisms were based on previous studies that were done with the previous SARS epidemic and the MERS, the Mediterranean variant. And there is some data coming from the ongoing COVID-19 pandemic. And this is kind of a busy slide, but I'm going to go over it. This is taken from a paper published in Nature about a year ago, and basically showing the possible mechanisms for the cardiac involvement in COVID-19. So the first mechanism that was suggested is direct viral injury. As you all know, the virus, the SARS-CoV-2 virus, penetrates the host cells, causing cell death. But there is very little data about the SARS-CoV-2 virus actually penetrating cardiomyocytes and causing cellular death. So this is probably not the main mechanism that is involved with the cardiac injury in COVID-19. The second mechanism that was suggested is the up and down regulation of the ACE2 enzyme. As you all know, the ACE2 enzyme is very important. It takes the angiotensin II and converts it into the angiotensin 1-7, basically stopping this cascade of the function of the angiotensin II. But the SARS-CoV-2 uses the ACE2 in order for it to bind to the ACE2 receptor and penetrating the whole cells, so causing less bioavailability of the ACE2 protein and downregulation of the ACE2 and ACE2 receptors, and thus causing the angiotensin II to be more active, causing more vasoconstriction, more inflammation, more fibrosis, and more proliferation, ending up with hypertension, more cardiac fibrosis, more thromboembolic events, and the patient is more susceptible for ARDS. This is probably the best mechanism that we have so far. The third mechanism is the cytokine release syndrome. So as you all know, in severe cases of COVID-19, we have this cytokine release syndrome that is basically the upregulation of some cytokines such as interleukin 6 and VEGFR. All of those actually causing the production of reactive oxygen species, causing more apoptosis and causing cellular injury. We have very little data about this kind of mechanism in cardiac injury. There's still a lot of work to be done about that. And the fourth mechanism that was suggested is the drug-induced cardiotoxicity. And when I say drug-induced cardiotoxicity, I mean all those drugs that we use to treat the severe cases of COVID-19. And here you have the list of several drugs that are used in treating severe cases of COVID-19. And you see we have the antiviral drugs, we have the some antibiotic, etc. And you see that regarding the antiviral drugs, we have some data about those having some kind of cardiovascular adverse effects. And as you all know, that azithromycin and chloroquine, hydrochloroquine, all those may actually cause QT prolongation, promoting arrhythmia. So if we take all those mechanisms, this is a summary slide showing you all the possible mechanisms. So you have the direct viral attack, you have the up and down regulation of the ACE2 and drug-induced toxicity, cytokine release syndrome. All of those may actually aggravate any underlying cardiac disease if there is one, causing cardiac injury and myocarditis, heart failure, and arrhythmia. From the beginning, the knowledge about and the data about the cardiac involvement in COVID-19 came basically from the symptoms, ECG, and troponin levels. But going into the pandemic, we started using echocardiography to show the cardiac involvement. We mainly saw most of the data that was published showed the some kind of RV dilatation, RV dysfunction. Some other papers showed LV dysfunction, regional wall motion abnormalities, and obviously some kind of pericardial effusion. Now we actually use more CT and MRI. So CT is basically used to rule out any coronary artery disease that may be the cause for any cardiac injury. But CT can also show you pericardial effusion and give a lot of information about the surrounding area of the heart, such as the lungs. But probably the best tool that we have today is the MRI, because MRI can give you information not only about anatomy and the function of the heart, but it can also give you information about the tissue itself. We have sequences for tissue characterization that we can use, and I'll show you later how we use those. So MRI actually became a very important tool for the cardiac involvement in COVID-19, so much so that the Society of Cardiovascular Magnetic Resonance, the SCMR, published this position paper about the recommended CMR protocols for scanning patients with COVID-19. And as you can see here, these are the protocols that were suggested in order for you to get the best information possible. There is the minimum requirements, the desirable ones, and the optional ones. And we basically use those for our research. So with the introduction of CMR into the COVID-19, let's say, more and more data was published about the abnormal cardiac findings, abnormal CMR findings that we show in COVID-19 patients. And recently, there were two very good meta-analyses that were published. The first one is by Kim et al. And they actually showed that in nearly half of the patients with COVID-19 that you will scan with MRI, you will find some kind of abnormal CMR findings. They show that in basically 14% of the cases, you will find evidence of myocarditis. And in almost 21% of the cases, you will find evidence of late gadolinium enhancement, meaning scar. The second meta-analysis that was published by Hassani et al., covering more or less 3,000 COVID-19 patients. This meta-analysis showed that the rate of raised T1 values, meaning cardiac fibrosis, varied across the studies from 0% to 73%. That's a huge gap there. And for the T1, for the T2, the raised T2 values, meaning edema, the range was from 0% to 60%. And for LGE, late gadolinium enhancement, meaning cardiac scar, it ranged from 4% to 100% of the cases. Just try to think about you taking all your COVID-19 patients, scanning all of them, and finding scar, cardiac scar, in all those cases. So that leaves us with a few knowledge gaps that needed to be answered. The first one was, what is the true prevalence of abnormal CMR findings in post-COVID-19 patients? As you saw, the variability is very big, and we needed to understand what is the true prevalence of those abnormal findings. The second is, what is the nature of the myocardial injury? Is it ischemic? Is it myocarditis? Is it cardiomyopathy? Is it something else? Is it all together? We still don't know. The third gap is, are those changes permanent or temporary? And if they're temporary, when should we scan those patients again? If they're permanent, what should we do with those? And the first question, maybe the most important one, is what is the clinical relevance of those abnormal CMR findings? So our study goals, the first one was to evaluate the true myocardial injury and inflammation, the true prevalence of the myocardial injury. And we took a very high risk cohort of patients, of recently recovered hospitalized COVID-19 patients with elevated troponin levels during their hospital stay. We chose this population because we thought that in this population we'll find more prevalent CMR, abnormal CMR findings. The second study goal was to actually characterize the specific population with positive CMR findings and to compare this subgroup to the group with totally normal CMR study. And the third goal was to compare our results with previous studies from the literature. We prospectively enrolled 74 patients from 2 sites affiliated to the University of Toronto. The first is Sunnybrook, and the second is Michael Garron. We started in July 2020 and recently finished it by October of 21. All of our patients, as I said, were hospitalized due to COVID-19 and had elevated troponin levels during their hospital stay. All of our CMR studies were done on the 1.5 Tesla device that we have here in the RCCI. It's a GE machine. And our protocols were based on the ones published by the position paper of the SCMR. We did cine images for anatomy and function. We did tissue characterization by T1 and T2, again, for fibrosis and edema. And we injected gadolinium for late gadolinium enhancement for the evaluation of myocardial scar. For those who are not very familiar with the details of CMR, both T1 and T2 values are dependent on not only on the patient, but they're very machine dependent. So we took 10 healthy controls, we scanned them without injecting gadolinium, just for T1 and T2 to establish our normal values for our magnet here. All the information about the patients were taken directly from their medical records. And I'm just going to say that we started off with 74 patients selected and scans. In 5 cases, the scan was in very low quality, so we couldn't get our information. So we ended up having 69 patients for our study. The average time that from the onset of the symptoms to the scan itself was 136 days plus minus 51, meaning 3 to 6 months. And I'm just going to say it here that in 21 out of 69 of those patients, meaning 30% of the patients that were scanned, we found some kind of abnormal finding. So that is quite, this is very similar to what was seen in the literature, but again, I'm reminding you that our population is a very high risk one with elevated troponin. So we kind of expected it to be higher. So let's just dive into the results and see what actually we found. This is our table 1, patient characteristics. You see the age was 58 plus minus 14. 69% of the patients were male. The BMI, kind of overweight, I guess, 28, ranging from 25 to 31. And regarding the risk factors, the cardiovascular risk factors, you'll see there. So 43% of them had hypertension, followed by 30% of the patients having hyperlipidemia and 28% having diabetes. This is very similar to what was previously published in the literature. About the clinical parameters on your right side here, these are the vital signs taken in eMERGE on presentation. So basically our population was kind of stable. I'll say that you see that systolic and diastolic blood pressure was fine. The heart rate was 94, ranging plus minus 16, and the oxygen saturation in room air was 93%. And on your left side, these are the values of the blood work. We took the peak value during hospital stay. So for white blood cells, the median was 6, ranging from 5.2 to 8. That is basically in the normal range. The CRP, the median was 58. That is elevated. The normal range is below 5. And for those patients that where BNP was drawn, so the median was 163, ranging from 148 to 210. So let's start talking about what the CMR findings. And we'll start with the easiest one. It's the LV function. So the mean LV function in our cohort was 59%, rating plus minus 8. And here on your left lower side, you'll see we have reference values for LVEF and RVEF for MRI. So comparing our results to that, we found reduced LVEF in 5 patients, meaning 9% of all the cases. But in only 2 of them, there was no previous ischemic injury. So in only 2 cases, we actually found an abnormal reduced LV function in a non-ischemic way, meaning only 3% of the cases. And the same thing for RVEF, the mean was 61 plus minus 8. And we found reduced RV function compared to the normal reference values in 7 patients, 11% of the cases, and with no previous ischemic injury in only 6 patients, meaning total of 9% of the cases. Going over to the LGE again, scar, we found some evidence of LGE in total of 9 patients, again, 11% of the cases, and in a non-ischemic patterns, meaning there was no previous ischemic injury in only 6 patients, meaning 10% of the total. And again, I'm just going to show you what I mean when I say non-ischemic pattern of late gadolinium enhancement. So here on panels A and B, these are taken from the same patient. You see this fine, starting from here, this is brighter, but you see this fine white line here in the mid wall of the myocardium. In this case, this is the intralateral wall. You see it in the long axis here and in the short axis here. These are again from the same patient. This is non-ischemic pattern of LGE. And here on panel 3, kind of the same thing. Again, this fine white line here in the mid wall of the myocardium. This is in the inferior septum, as you see in the short axis. Again, this is a non-ischemic pattern of LGE. And when I say non-ischemic pattern, I'm just going to show you what I mean when I say ischemic pattern. So again, these are taken from the same patient that I showed you previously. But here in panels C and D, you'll see that you see this scar here, this very bright white scar, starting from the subendocardial layer, going actually the whole thickness. This is of the myocardium. This is transmural scar here, basically corresponding to a specific coronary territory. This is inferior wall, so corresponding in RCA territory. And we went back to this patient's medical records, and we saw that this specific patient had an inferior STEMI about 3 months prior to him being diagnosed with COVID-19. So we excluded all the data coming from this patient. And again, I'm just going to show you the cine images from the patient with the ischemic scar. And you'll see that there is a regional wall motion abnormality here. The inferior wall is hypokinetic compared to the rest of the myocardium. You see it here in the long axis, and again here in the short axis. Continuing with the abnormal CMR findings, going into the tissue characterization, our native T1 values, again, this is the significance for cardiac fibrosis. In our study group, the mean value was 936 milliseconds, and in our normal control group, it was 930, and you see that there was no statistically significant difference between the two groups. And abnormal T1 values, we actually the abnormal T1 values were calculated by taking the mean value here plus minus 2 standard deviations from the normal controls. So abnormal T1 values were found in 8 patients, a total of 12%, but again, with no previous ischemic injury, only 6, meaning 9% of the patients. The same thing for native T2, again for cardiac edema. The range for the our cohort was 42 and 40 for normal controls. Again, no statistically significant difference between the two groups, and abnormal T2 values were found in 2 patients with no previous ischemic injury, and meaning 3% of the patients. So just to summarize this part here, we found abnormal CMR findings in 18 patients, meaning 26% overall. Again, we kind of aimed higher. We took a very high risk cohort and we thought that we will get higher numbers, but this is what we got, 26%. The total number of abnormal CMR findings was 22. The most frequent abnormality was the elevated T1 values, followed by LGE and reduced RVEF. And back there was the elevated T2s and the reduced LVEF. This is very similar to what was previously published in the literature. The second part of our study was to compare the subgroup that had abnormal CMR findings to the group with basically normal CMR study. So for patients' characteristics, basically the same. The mean age was basically the same, 61% male here and 67% in the normal CMR studies. Height, weight, BSA, BMI, all basically the same. We looked about maybe there is some difference in the number of risk factors, of cardiovascular risk factors, but again, there was no difference between the two groups. As you can see here, the number of risk factors, the one that with no risk factors is basically the same. 1 risk factor and 2 or more risk factors. There's no difference between the two groups, and there is no difference between the two groups, even comparing for vital signs. We took a further look into the risk factor itself, and we did a univariate analysis on those, comparing the two groups. And we found out that basically there is no statistically significant difference between the two groups in any of the risk factors, all but 1. I'm going to show you here. Prior CAD is the only risk factor that was actually statistically different between the two groups. As you see here, 22% of the patients with some kind of abnormal CMR finding had prior CAD, but in the group with no prior CAD, only 4% of the patients with the p-value of being 0.02. The third part of our study was to compare our result with previous studies that were published in the literature, and we chose this study here by the Puntman group. This is a German group. This study was published about a year ago, And as you can see, these are our results compared to their results here. So LVEF, we found it to be 59 plus minus 8, and their results were 57 plus minus 6, basically the same. RVEF in our case was 61 plus minus 8, and in their case, they found it to be lower, 54 plus minus 7. But the big difference was in the tissue characterization. So you see that with the LGE, we found LGE in a non-ischemic pattern in 10% of the patients, where in their study they found it to be in 20% of the patients. In our study, we found abnormal elevated T1 values, again for fibrosis, in 9% of the cases. And as you can see here, they found it to be abnormal in 40% of the cases. And again, for elevated abnormal T2 values for edema, we found it to be elevated in 3% of the cases, and they found it to be significantly abnormal in 22% of the cases. We thought we were trying to understand what is actually the cause for this difference. We compared the study population, and basically what you can see that their study population was younger, healthier, and only 33% of their patients were actually hospitalized, and in only 70% of their patients, only 70% of their patients had elevated troponin levels. So again, I'm struggling to understand why we have such big difference between the two studies. So I'll start my discussion by saying that, as you saw, recent meta-analysis demonstrated that abnormal CMR findings may be found in up to 50% of the patients recovering from COVID-19. But our data shows that CMR findings, elevated T1, abnormal T2, LV and RV dysfunction, or LGE, we found it in only 26% of the patient. And again, even though our study population actually included very high-risk patients with elevated troponin levels. The most frequent abnormal CMR findings that noted in our study were elevated T1s for fibrosis, reduced RVEF, and LGE. All of those are consistent with the previously reported findings in the literature when using either echocardiography or CMR. And it also appears that it's not the number of risk factors that actually influence the probability of having any abnormal CMR finding, but the risk factor itself, as you saw, prior CAD, does correlate with higher probability of having some kind of abnormal CMR findings. And I know this question is going to pop up in some point, so I'm just going to say it here. All of our patients were actually got the vaccine after the scan or not at all. We do have some patients that chose not to get the vaccine. So none of these findings can actually be attributed to the vaccine itself. I'm going to leave you with some discussion points about this study. So the first one is, why do you think there is such a big discrepancy in the prevalence of abnormal CMR findings between the studies? And what do you think is the role, the mechanism of previous CAD in the myocardial injury? And as clinicians, well, probably this is the most important point here. So as clinicians, what would you do with those patients? Let's say a patient coming to your office saying, oh, I had elevated T1 values on my MRI scan. What do you say? What do you recommend? Should I get any treatment? Should I need to be, do I need to get another scan? Can I go on vacation? Can I exercise? I don't know what we should do with all those patients. And before I finish here, I'm just going to say thank you very much to our study team. Dr. Roishman, thank you very much to that. And Nilesh, Bonnie, Kim, Adrian, Dr. Strauss, Dr. Wright, Judy, and Mary. This is all of us skydiving a few days ago. I'm just joking, of course. And thank you very much for all your attention, and open for discussion. Thank you.
So maybe I'll ask you to just close the slide so you can see people who may be asking questions. I see, Ida, why don't you lead rounds? I know Eric has to come in and chat.
Eddie, that was excellent. Thank you. Just to clarify one point, so all of our patients were actually also hospitalized for COVID-19. We could look, I don't have the exact mean amount of stay, length of stay in hospital, but some of them were hospitalized for a prolonged period of time. And still we found that the number of abnormalities in cardiac MRI are relatively small, considering when compared to the other studies that have been published, especially that German study. And I would say that the magnitude of the abnormalities are also really small. So you have little abnormalities in T1 and T2, and some in late gadolinium enhancement, which is a bit more robust of a sequence. But when you consider the whole thing, it seems that the issue of cardiac injury in COVID may have been a little bit overplayed, over-exaggerated at the beginning of the pandemic. And now this is one of the studies, and others have preceded us, and less high-risk populations have shown that it's less common than we thought. So it's still there for sure. It's still something to consider. It's not an insignificant number. Let's say about 10% of patients have significant abnormalities, but it's not what we thought at the beginning, or at least what was reported at the beginning, which was about 70%. Okay, so questions. Eric, you had one?
I think Eric has a question first.
Yeah,
Eric.
That was great, Eddie, and thank you for that. And it's really good work you've done. I put my question in the chat, but I'll just state it again, because I actually wondered right from the start. COVID has presented a huge opportunity to study this infection, because you've got a ton of confirmed diagnosis in patients. You've got a captive hospitalized population, and it's affecting millions and millions of people in the world in a very short time frame. But if you could study other viruses, or somebody studied other viruses and not just coronaviruses in a detailed way like this for cardiac involvement, like does influenza give you subtle changes on cardiac MR, for example?
So I don't think there is this equivalent work about influenza regarding CMR changes, not at that magnitude, obviously. We do know that in some cases we see myocarditis caused by the influenza virus, but I don't think we have data, corresponding data about that.
If I could just ask a follow-up, because there's a second part when we're talking about specificity between, SARS-CoV-2 and the heart. What about between SARS-CoV-2 virus and other organs? So we have extremely sensitive tests to look at the heart, like troponin. You just sneeze and your troponin can go up. But for example, the achiness, the muscle aches that people get with almost any virus, but certainly with COVID. If you did MRI on skeletal muscles, do you see some of the same changes? I'm just getting at whether the heart is just a bystander organ like every other organ in the body that gets caught up in the inflammation when you have a systemic viral infection.
Well, I'm not MSK, so I don't know exactly how to answer that. I do know that we have a parallel work that is going on and scanning the lungs. So I guess it will be published soon, and you'll see the evidence about the that we have about lung scanning in MRI, but I don't know about the skeletal muscle.
Okay, well, thanks. I'm just trying to put this in a broader context, but I appreciate the talk you gave. It was very, very informative.
Thank you.
Just maybe a follow-up to Eric's question, then I'll go to Marco. Are you aware of any other vascular beds that are affected? There's, there's talk of COVID being a vascular disease, and are you aware of that kind of link that may link it to the heart in an indirect kind of way, along with the brain and other things?
Are you asking Adi or
Adi,
me?
yeah, Adi.
Can you repeat the question?
Yeah. So Eric was mentioning different organs, right?
Yeah.
So there's obviously many different organs, but are you aware of a vascular link that's been sort of made with COVID that potentially can link it to other organs aside from the heart, like the brain and things like that, in a preferential manner, as opposed to different organs that don't have, like musculoskeletal, that don't have the same.
No, I think it's just lungs. I didn't see any work done about any other vascular organ. No.
Okay. Marco?
Adi, thanks for the interesting research and talk. So my question really has to do with the generalization of findings to critically ill patients in any context. If you look at ICU patients, many of them have elevated troponins or other signs of systemic inflammatory response that could include cardiac depression. So really my question is, do you have any ability to comment on whether the findings are specific to coronavirus or whether they might be representative to a more general ICU population who's sick enough to be in hospital or in an ICU for that matter?
Well, we do scan. We tend to scan a lot of ICU patients, and obviously, I can't say that I've seen a lot of CMR findings in those cases with just very sick ICU patients with no elevated troponin, and even if with the elevated troponin, I don't remember seeing such a very significant cardiac involvement there. Idan, you are on mute.
I think both of you bring up a very good point, Eric and Marco, though. This disease has been studied perhaps more than any other disease in the history of diseases, right? If you think about the time which it came and the amount of money that's been poured into it for research. I think Eric's point is a good one about influenza. No one has done that study. So it's possible that you could have these subtle changes as well, right? But I think that one of the take-home points from our study was that the changes are a lot less than what were previously reported, and most of them probably won't be permanent. So it'd be interesting to see if we could scan these patients again in 6 months to a year, and we're thinking about doing that as well, to see how many of the abnormalities actually went away over time. But I'd imagine that most of those, especially the ones without gadolinium enhancement, would not be permanent. So that's an encouraging sign. Cam?
Adi, I thought that was great. Thank you. I had two questions. One of them was the time issue and whether, the variability in the different studies relates to the time of the MRI relative to the disease. And Idan just commented on that. My other question was related to the reproducibility of the findings. I'm not sure who read the echo or the MRIs and whether more than one person did, and whether you knew whether it was a control patient or one of the study patients. Because it seems that some of these findings are soft, like echo, and obviously is part of the issue between the different studies, just the variability in the interpretation of the findings.
Yeah, so you're absolutely right, but with previous studies that were published, you're right that there is a very big inter-observer, let's say, inter-observer variabilities with echo, but with CMR, it's, I guess, less reader dependent, because it's the post-processing is based on the software that we're using. So, and it's partially AI, so it's more reproducible with MRI than with echo.
Was there more than one reader of these scans?
In our case, no, but in our other studies, yes.
Okay, thanks.
Moshe?
Moshe, you're on mute.
There we go. Sorry about that. I really enjoyed the talk very much. And I was just curious if the study had any implications with regard to vaccination. What I mean is the following. We know that the best predictor of future events are past events. If somebody has myocarditis after the first vaccine, it makes sense to withhold the second vaccine, right? Because we think that whatever caused the first one might cause the second one. If somebody has myocarditis or a suspected myocarditis after COVID infection, what do you think we should do with regard to vaccination? I know it's not directly what you were addressing in the study, but did the study reveal anything that might, either mechanistically or anything else that might influence our guidance?
That's a very good point, but I can say we didn't, it wasn't one of our study goals, but I can say that I was following, doing a lot of follow-ups on those patients. And in none of the cases of the patients that were actually vaccinated, I didn't see any raised troponin levels after the vaccine. So I guess none of them actually had any issues with the vaccine after.
I appreciate that. It's very helpful.
And maybe one other follow-up to that is, we've all been hearing about vaccine-induced myocarditis. And so the most recent estimates for that are between 1 in 10,000 to 1 in 50,000 people that get vaccinated. So to put that into context, our study here looked at a very, very high-risk population, small, but high risk. And we found amongst the lowest prevalence of cardiovascular abnormalities out of the other studies that were done in this area. And it was still levels of magnitude higher than what would be expected from vaccination. So something to keep in mind for those people who claim that, that vaccines are dangerous relative to, everything has to be relative in life. And here it's relative to COVID infection.
A couple of, there's some questions in the chat room,
Okay, is there a position statement on who needs an MRI for COVID myocarditis?
No, there isn't. Again, myocarditis, it's basically your clinical suspicion and based on other clinical findings and blood work. So, and now you'll see we have referrals for basically everything about everything, and because of the suspicion for myocarditis. And so there is no position paper about that. But again, it's based on the guidelines. It wasn't changed.
Okay. Okay, great.
I think there is a question from Dr. Wright.
Oh, yes. Okay, so Graham asked differences between the diagnosis and the scan in terms of time and correlation of T1, T2 with age. Are younger people more prone to a strong inflammatory response?
That's
so in other words, because the German study looked at younger people overall, a less high-risk population, maybe that could explain why their T1 and T2 values were potentially higher because they have more inflammation. I think that was one of the questions. And then the second one is the time difference between the scan, the diagnosis and the scan. So what do you think?
So as I said, in our study, the timing was between 3 and 6 months between the diagnosis and the scan. In the German study, it was, I think, 2 and 3 months. So maybe their findings are more, maybe they have more findings because they scanned sooner. And about age, probably I can look after it, but I don't know. We don't have the answer for that right now. That's a very good question.
Thanks.
Can I just come back for what, just to sort of bring this full circle? Because the question about the vaccines is a good one, obviously, but part of this comes down to, I think, can you, and your data set may not be large enough to get an insight into this, but perhaps by pooling all the data sets, you know, the one question is whether you just see a distribution of abnormalities ranging from no abnormality at all to some subtle abnormalities in a relatively large number of people to severe abnormalities in a very small number of people. So, you know, whether you look at the heart or whether you look at the respiratory effects of the virus or whatever, do you see a normal distribution of effect? Or do you see a really discrete phenotypic difference where you have some people that have no adverse effects and some people that have very severe adverse effects? And then it becomes important to look for the associated factors that identify those people with the severe effects. For example, if you're thinking about who should not get subsequent vaccine doses, versus if it's a common effect that everybody gets, but we just get it in a distribution of severity.
Okay. You want to answer?
More a comment than a question, I guess, but it is potentially pooling data to look at. For, you know, I mean, all of the MRI studies are not involving thousands of patients. They're individually smaller, but if you ultimately put the data together, perhaps you have a normal distribution of MR abnormalities here, or a skewed distribution, but at least some describable distribution.
Could be, that's a very good point.
If there are no other questions, I really want to thank Idan and Eddie for doing rounds. I think it's, wow, she talked about, you know, COVID and kind of seems a bit sarcastic. I think people are still quite interested in this topic and would like to learn more. I think one of the things is that, you know, I think people want to know is what happens long term, right? Do people have heart failure and something, arrhythmia and things? I think that's, I'm sure that's to be seen. But thanks a lot for your work and thanks a lot for presenting, and hopefully everybody enjoyed it. And thanks the audience for coming. It's always been a great discussion we have for rounds. So thanks a lot.
Thank you very much.
Bye, everybody. See you next week.
Bye.